Bianca, thank you so much for joining us today and for giving us this talk. I will hand over to you.
Thanks so much, Keisha. Let me just get this in the right view. Okay, cool. So yeah, thank you so much for the opportunity to speak about this topic today. As mentioned, my name is Bianca and I'm a PhD student currently based at the University of Cape Town. The PhD is focused on non-sputum-based diagnostics, but for today I'm going to be sort of speaking a bit more broadly about TB diagnostics in general in patients with HIV. So as I'm sure many on the call know, patients who have HIV with TB present in a very different way to those who are HIV negative. Not even the chest x-rays read the textbooks, like you can see on this slide. And that's kind of the crux of why there's so much to be discussed on this particular topic. For today, I'm going to be ultimately focusing on microbiological diagnostics, so not really much of a focus on others like radiology, but if there's time, we can maybe come to it at the end. I'm going to be focusing on what is recommended by the WHO specifically, but we'll mention some other sort of up-and-coming potential diagnostics with that. And I've split the whole talk as well into inpatients versus outpatients because they're quite a different approach to these diagnostics in those two groups. What I'm specifically not talking about today is screening approaches or active case finding algorithms. That's kind of a whole different topic on its own and is a step just before diagnostics. I'm also specifically not talking about treatment monitoring and drug resistance diagnostics. And then just to also highlight that I'm not speaking about site-specific diagnostics. So what I mean by that is if a patient perhaps has TB lymphadenitis or TB meningitis, we of course may do lymph node aspirates or lumbar punctures in those cases. But what I'm going to be focusing on today is the diagnostics that can be used irrespective of the site of disease in all patients presenting. So just to start with a bit of terminology so that we're all on the same page, there's a specific list of rapid diagnostic tests that are recommended actively by the WHO, some of which I've put just into this table. What's very useful is that more recently they've separated these into different classes of tests. So you can see they separate out low complexity tools from moderate complexity tools, and that's specifically with regards to the nucleic acid amplification tests. And the complexity is just ultimately with regards to how easy those tests are to perform, what sort of pre-processing steps are involved, and for example, whether they require electricity or can survive with battery power. Some of these will be very familiar with already. So the Expert Ultra in many settings is available. Other settings may have access to one of the other low complexity tools like TrueNat. And then just on the list here, some of the moderate complexity tools. We're of course all likely familiar as well with the class of antigen detection tools, which are commonly performed at point of care. And the only WHO recommended of these is our urine LAM test, which I've also put as an image of on the slide, just so that we can all kind of follow the fact that whenever I refer to a urine LAM or an allele LAM, sometimes referred to as determined LAM or Aleph LAM, I'm always talking about this particular LAM tool, which is pictured here and with the reference card, unless I specify otherwise. So why are we sort of worried so much about rapid diagnostic tools, and particularly the WHO recommended ones? At the recent second UN high-level meeting that happened on TB last year, they kind of set out an agenda to aim for 100% coverage by 2027 with regards to patients being diagnosed with TB based on one of these rapid diagnostic tests. So how are we doing with regards to that? So this is just the WHO figure based on data in 2021, which of course was a difficult time in the world, but is still reflective of what might be happening. I've just highlighted here in the middle South Africa, where I'm based, which kind of sits somewhere in the middle of the various countries. There's a lot of variation as to how much coverage we've got, but the essential message is that we've got a long way to go to achieve this goal. So as I mentioned, we're going to split the talk today on diagnostics for HIV-TB in hospital, and then for those at clinic level. They're sort of two very different potential presentations of patients with HIV-TB. We know that TB is the leading cause of death in those with HIV, and that it's the leading cause of hospitalization. When patients with HIV-TB present to hospitals specifically, they generally present with a much more severe form of this disease. And in a large meta-analysis, it was estimated that around 45% of these patients with TB will have TB detected on a blood culture or TB bloodstream infection, sort of demonstrating that the bulk of these cases are presenting with a very severe, higher mortality risk form of TB. Unfortunately, with these deaths, they happen early. And so we also know from this meta-analysis that if treatment delays happen just within a matter of days, there can be even further additional risk of mortality in this group. And so there's a big push for diagnostics that can specifically make a rapid diagnosis in these cases, and that would allow for rapid initiation of treatment. What we currently rely on in this group is ultimately a sputum test and a urine lam, which I'm going to go into a bit more detail. But persistently, with both of these tools available, many of these patients remain undiagnosed. So just to come back, now familiar with this table, I'm going to just speak specifically about 3 examples of these nucleic acid tests. 2 of the low complexity ones, which you may all be familiar with, and then 1 of the moderate, just as examples. So expert is a sort of form of testing on sputum that we're likely familiar with. The expert initial cartridge has been available since around 2011, and then there was a move to expert ultra in around 2017. In those with HIV, we know that the sensitivity is around 88% on sputum, and that specificity sits at around 93%. TrueNat, one of the other low complexity tools, and which is sort of a much more point of care kind of test. It can run just on kind of in your desk in the clinic with battery power. Also has the TrueNat MTB, and then more recently the MTB Plus. But the sensitivity of that sits somewhere in between the sort of expert older cartridge and the more recent expert ultra, as the specificity of the newer one sits at around 96%. As I kind of mentioned, I'll just give one example of the moderate complexity tools which are being rolled out. And the sensitivity and specificity are much more similar to the expert ultra test. And if you are based in South Africa, you may start seeing already that some of the results when you send off a sputum test actually might be coming from this BD platform. You don't have to worry that they've done the wrong thing. It's still testing for TB and has a very similar accuracy to expert ultra. Then coming to urine lam. So this is, as I'd kind of mentioned already, this is the only lam tool or urine-based tool that's been WHO recommended for the point of care or at the bedside. While it's very handy to kind of be able to perform this at the point of care, it's important and critically important that we perform this test properly, and sort of variable levels of training have happened with the rollout of this test. So for example, I've pictured here the reference card, which is important to use when interpreting the test. It's important to know what sort of timing, so to read the test at 25 to 35 minutes, and other things sort of, for example, using a fresh urine sample has an impact on how accurate your test would be. So with regards to a Cochrane review on its accuracy for inpatients, the sensitivity sits at around 52 to 62%, depending on how you split the cohorts. And then the specificity sits at around 84 to 87%. So it's important to remember at scale that there are many patients who truly do have TB who will be missed by this test, even though it's particularly useful. And there will be expected to be some who are false positive. So when you do this test, it's important to kind of take a step back. If it's positive, initiate your patient on treatment. But in all cases, it's important to do follow-up testing for confirming the diagnosis, checking for rifampicin sensitivities, and if the lam was negative, to still continue looking for TB. While we know that there's sort of these nuances to the implementation and potential accuracy constraints, what we do know about lam and why it's particularly useful is that it's been shown to save lives in randomized controlled trials. So I'm going to speak about 2 of these trials that may be familiar to many of us, and then a third one that's come out more recently, and some of the sort of similarities and differences between them. The first came out in 2016 by Johnny Peter and was based on inpatients in a few different African countries. They enrolled patients specifically who had TB symptoms and performed the LAM or allele LAM at the bedside. Based on those results, they then gave the clinical team advice about whether to start TB treatment or to continue testing with other tests. The second one that came out in 2018 by Bianca Wright was specifically unselected inpatients, so they didn't worry about whether the patients were having TB symptoms so long as they were admitted. And then the intervention arm in this trial got LAM and a urine expert, but it was specifically performed in the lab, so not at the bedside like the first trial. And based on either of those, so the urine LAM or the urine expert being positive, the study team then fed back to the clinical team and said one of these tests is positive and advised with regards to treatment. In these trials, there was an absolute survival benefit, particularly for the ill patients being admitted, of 3 to 4% at 8 weeks. So this is a particularly compelling reason why we use this test. It's not usual for a diagnostic test to be able to save lives, but it's what a lot of the recommendations were based on. More recently, there's been quite an interesting additional trial that's come out. This was based in 3 hospitals in Ghana. Just to highlight, it specifically wasn't powered to assess the question of mortality. The primary outcome in this trial was time to initiation of the TB treatment. They enrolled here inpatients with either TB symptoms or having advanced HIV. And as you can see, the kind of primary outcome of time to initiation of treatment didn't differ between the control arm and the intervention arm. It was 3 days in both. And what's a little bit alarming is that in the control group, who just had sort of standard of care testing, there was less mortality than in the intervention group where LAM was available. What is important to highlight as a difference in this trial is that, so it was a cluster randomized trial, and in those clusters that had been randomized to the intervention, they did a training of the clinicians who were working in the sort of routine service about how to test for TB, both with regards to who should get sputum testing and with regards to who should LAM, and taught the clinicians themselves how to perform the test themselves as well. And then thereafter interpret the results and act on those results. So it was trying very much to reflect a real world practice and removing the testing of LAM from the study teams and giving it into the hands of the clinicians. One other major thing that could potentially bias these results is the timing that this trial happened. So it initiated in around 2019, and as of course we happened and up until I think 2021, 2022 when the trial finished. So the interventions arms had a much more overlap with the COVID-19 pandemic. And so that may play a role in why there was this unexpected increase in mortality in the intervention group. But we can't kind of attribute everything to that problem. What I've just shown you is just, if we focus in on these figures, in the control group, I hope you can see my mouse moving, but in the top figure in the control group, you can see that we see here essentially how many tests are being performed, the blue being how many experts are performed. And then in the intervention group, you can see, of course, there are many more tests being performed in patients, both experts, which became more, and of course the addition of now having LAM available. And in these kind of other plots, you can see how many tests were positive. So the proportion of TB tests when just relying on expert sat at around 5%, but once we had LAM available, many more diagnoses were made. But despite these diagnoses, as we kind of heard from the primary outcome, there wasn't a difference in time to treatment initiation. So they tried unpacking this a bit more. And when you come to who was eligible for LAM, there was a drop-off when this was performed just in routine care with regards to who actually had the LAM performed. Of those, there were, of course, a subset that were LAM positive, and only 46% of the positives got initiated on TB treatment. So there's some sort of disconnect that's happening in this particular trial with regards to actually accessing this test and then the resulting treatment initiation that goes with it. And they do go into sort of trying to break down the reasons for this disconnect. And they mention in some patients it was timing, and unfortunately patients died before the LAM could be performed or before they could be initiated on treatment. But in others, they highlighted just communication issues amongst the clinical team, and also kind of waiting for the expert result to come out before they decided to initiate treatment, even though the LAM was positive. And a reminder that this was all in patients, either with TB symptoms or advanced HIV. So there's a lot to reflect on here in this new trial that's come out, and a lot of sort of implementation science work that needs to go into this to fully understand it. So as I kind of mentioned, we focus in hospital on sputum tests and LAM. I'll highlight the specific indications for that shortly. And then, of course, we know that, as I had mentioned, we may perform other tests like a lymph node biopsy or a lumbar puncture if you think your patient has focused disease in those sites. But how is the sputum and the urine LAM doing so far? So this was a meta-analysis that looked at patients overall with regards to how many were being diagnosed with TB within the first 2 days after presentation. And then I'm showing here also the subset of inpatients. So overall, LAM was able to diagnose 41%, and this went up to around 50% in the inpatients, the LAM being the green circles here as part of this Venn diagram. Sputum expert overall could diagnose 61% of patients within 2 days, but this dropped off quite a bit in the blue circle to 48% in inpatients. And that's primarily because these patients are very ill and less able to produce a sputum sample, or certainly less able to produce it quickly. And with regards to when we have both of these tests available, in inpatients, we're still missing 28%. So 1 in 3 patients who are hospitalized with HIV-TB remain undiagnosed with these two tools available. So we've still got a long way to go. What I'm going to come to now is some of the work that's been going into trying to expand beyond that diagnostic yield and try and make diagnoses in more patients. So this is a study by Dr. Linda Boloko, a clinician researcher also at the University of Cape Town. And just like the expert that we would perform on sputum, he did a study performing expert ultra on blood, on whole blood with a few kind of processing steps before. The expert ultra on blood definitely outperformed a blood culture, and the overall yield sat at around 37%. And this yield increased in the patients who were sicker, so those with high lactates or high risk of mortality. And interestingly, it's currently actually sort of conditionally recommended by the WHO as a tool for diagnosing disseminated TB. So that's one potential to watch. There are, of course, upcoming LAM assays that are being studied. The ones that I've listed on the table here are definitely not an exhausted list, but such as some examples of a huge amount of work going into trying to develop new LAM assays. We were hoping that what's called the Sylvamp TB LAM or the Fuji LAM produced by Fujifilm was going to be a potential front runner and kind of change the whole dynamics of TB diagnoses for HIV in hospital and in outpatients, based on retrospective studies that were on biobanked urine. But when this test was used in prospective studies with kind of bedside testing on fresh urine samples, there was lot-to-lot variability that was picked up in the assays. So there's some sort of QC manufacturing issue that was picked up, but the manufacturers have suggested that there's potentially a new version of this test coming out, and we're hopeful that between that or one of the other LAM tests that's being developed and studied, some of which are listed on this table, will mean that we'll have a new LAM assay that can improve on the currently available one. Then what about sort of, just like I had said for expert on blood, we can also potentially perform expert on urine. And there's been promising literature on urine expert for almost 10 years now, but the policy uptake on this has been quite slow. So again, this is using the same cartridge as a sputum sample, but with a concentration step applied to the urine. So centrifuging it for just 15 minutes before actually running it in the test. We were involved in a multi-center study across 7 countries that we were able to assess urine expert ultra accuracy and diagnostic yield. And overall, it's appeared at least in this cohort to have a similar sensitivity to LAM, but a much higher specificity and positive predictive value. So we can be much more confident in a positive result truly being TB. And it mapped similarly to Alere-LAM in that it had a higher sensitivity in inpatients versus outpatients, and a higher sensitivity in those with lower CD4 counts compared to higher CD4 counts. With regards to the diagnostic yield assessment in our study, as you can see here, a sort of similar trend that I'd mentioned in the earlier meta-analysis, in that 27% of the cohort of inpatients were still missed by sputum expert and LAM. But the diagnostic yield, as I've kind of highlighted on the slide here, for urine expert ultra alone was 44%, so it could diagnose 44% of TB patients. If we had all three tests available, so LAM, urine expert ultra, and sputum expert ultra, 80% of our patients with TB could be diagnosed with one of these three tests rapidly. And as you can see from the Euler plot, there is quite a bit of overlap between the three tools, but there's also patients that are only positive by one of the three tests. So we really do think that this is a promising potential additional diagnostic. There have also been other studies that have looked at urine expert ultra, just to highlight another one. So this was also based on inpatients in two hospitals in the Eastern Cape province of South Africa, much sicker patients than the cohort on the left. So much lower CD4 counts, more TB, and a higher risk of mortality overall. And the diagnostic yield in this study actually outperformed that completely of sputum expert ultra, as you can see on the slide. Just under 70% of all the patients could be diagnosed with that test alone. And just to highlight, in both of these studies and some others that we've been involved in, urine expert ultra is actually the single best test when it comes to patients with TB bloodstream infection or disseminated TB, and it's able to diagnose around 80% of those. And as I'd kind of highlighted in the beginning, those are the patients that are presenting particularly sick and have a high mortality risk, or the highest mortality risk, and at great risk of dying if we don't start them on treatment quickly. So what's exciting on this particular topic is the urine expert ultra was recently endorsed by the South African TB think tank, which we see as promising, specifically for patients hospitalized with HIV, where resources sort of allow for this, and with a focus on patients who can't produce sputum. And it's also been listed by the WHO as an option for extrapulmonary TB diagnosis in this policy brief that they wrote about advanced HIV diagnostics. So we're hopeful that this will become routinely available for those patients who need it in the future. So just to summarize the patients in hospital, we know that there's great mortality risk and that we need a rapid diagnosis and rapid treatment initiation for these patients. We generally want to perform a sputum molecular test in all patients with HIV, particularly where the prevalence of TB is more than 10%, or in those with TB symptoms. And Alere-LAM is recommended in hospitalized patients with HIV if they meet one of these criteria, so seriously ill criteria, TB symptoms, advanced HIV, or CD4 counts less than 200. So essentially this lands up being virtually all patients hospitalized with HIV. A reminder for those who might be sort of working at the presentation point to hospital, whether that's in the emergency center or admitting these patients to hospital, you may not be the sort of provider that sees them for the few weeks after their treatment initiation. So you may not kind of be able to see the full effect of getting these rapid diagnostics and patients onto TB treatment. But hopefully, if we remember this data, we'll be sort of encouraged to get these tests done quickly and early on, soon after presentation, and get these patients onto treatment. We're hopeful that the testing algorithm will expand soon, potentially to new LAM assays, potentially to the urine expert or other molecular tests, or otherwise to try and decrease how many patients are being missed by the diagnostics available to us. So shifting gear a bit, we're now going to talk through HIV-TB diagnostics in clinics. In the recent WHO global TB report that came out, around 660,000 individuals had HIV last year. So this is now we're dealing with huge numbers. The majority of patients with HIV-TB will actually present to ambulatory level. So while there's still a high risk of dying here, and we need rapid diagnostics that can get patients onto treatment, we also need tools that can be performed at scale because of the sheer size of numbers that we're dealing with. So we know that luckily sputum performs a bit better in outpatients, which I'll come to shortly, but there still are patients being missed. And we need scalable tools to be able to essentially find these missing cases and get them onto treatment. The recommendations, again, for sputum molecular tests, is generally where the local TB prevalence is, again, more than 10%, or in those with symptoms. And the LAM recommendation is slightly different, just with regards to the CD4 counts. So instead of a CD4 count being indicated for LAM testing of less than or equal to 200, it's 100 in outpatients. So just to kind of visually present some concepts before I get into some of the data, if we can all imagine the people on our slides are standing at our ART initiation clinic as outpatients. And of these patients, we obviously know that some of them are going to have TB, and we want to know that before potentially they leave the clinic today, but that's not always possible. So if we imagine that a portion of our TB patients will be able to perform a sputum test, and potentially some of the rest unfortunately can't. Potentially they don't have a productive cough. Maybe they're worried about going into produce that cough in the site wherever that happens in your clinic, maybe because of the stigma that's associated with that. But ultimately, of your TB patients in your queue, only some of those can produce the sputum sample that we all rely upon. So even if we have a test that's 90% sensitive on sputum, which is an amazing feat, we're still only going to be able to diagnose those who could cough, and we're going to miss a fair number of the rest of the patients. But if we were to imagine being able to make a diagnosis on a much easier to produce sample, whether that's potentially a urine test or a blood test, there's also a huge amount of work going into swab tests like we were doing for COVID. And even if we know that those tests are less sensitive, let's say 75% sensitive, we're actually going to land up making more diagnoses than we would have if we had to rely on the sputum tests. So some much smarter people have used all of this information and put together a mathematical modeling study that's informed how we should be designing, or at least the manufacturers designing future diagnostic tests. And they've modeled this based on 3 different settings: India, Kenya, and South Africa. And it's a similar concept to what we just kind of went through. If we have a sputum test versus a non-sputum test, if we have a test that can be performed at the point of care versus at the lab, and of course at different TB prevalences, what we would hope for with regards to our test changes. So on our y-axis, the outcomes here, it's the number of individuals that are actually diagnosed and put onto treatment, and then with varying levels of sensitivity of the potential test. And you can see that the different colors, all the different options, have quite a different impact on what we would find with the various potential options available to us. But the WHO has since used this study and essentially applied this evidence to decide, well, what sort of tests should we actually be aiming for at scale? And if we have a test that can be performed at the point of care on a non-sputum-based sample, we can probably accept something as low as 70% sensitivity compared to if we were performing it on more complicated samples and in laboratories. So that's reassuring that potentially things are for the manufacturers. I definitely don't want this talk to be sort of seen as a bashing on sputum. And when patients can cough, we definitely still want to be able to send off those tests. So if you remember these figures from a bit earlier, I had gone through the differences seen in inpatients, but now I'm just highlighting in outpatients. As you can see, between the inpatients and the outpatients, LAM is sort of drops, so LAM in the green drops down to being able to diagnose only 34% of patients, whereas sputum expert jumps up in the blue, much broader diagnosis, to 70%. And that's generally because these patients are less ill and more able to actually produce that sample. But even with these two tests available, we're still missing 23% of cases. So well, close to 1 in 4, 1 in 5 ambulatory HIV-TB adults remain undiagnosed by these two tests. Urine LAM, with regards to its use in outpatients, has a slightly lower sensitivity overall, so sitting at around 29 to 31%, which is quite low. But specificity is a little bit higher, sits at around 95 to 96%. But the thinking of making LAM available in outpatients is, of course, to expand that survival benefit that I went over earlier, so that the sicker patients at clinic level can still benefit from this test. And as we know, in many settings, depending on resources, not all ill patients will actually be able to reach a hospital. So the hope is that those presenting to clinics can still access this test. In particularly outpatients, an area with very sort of big excitement and loads of energy and resources going into it is to try and develop a test similar to like what we had during the COVID time with regards to swabs, whether that be an R swab or a nasopharyngeal swab, different sites being assessed, also using different methods and different PCR tools being used, different swabs as well, whether that be a flocked swab or otherwise. Ultimately, there's a huge amount of heterogeneity that's being picked up. And so there's still a lot of work to do on this. What I'm showing here is just a meta-analysis that was published earlier this year with regards to specifically oral swabs. The ones that I've highlighted in green are two cohorts that had the majority of their cohort being HIV positive. And you can see that those two cohorts with regards to sensitivity here on the sort of middle of this panel sit somewhere in the middle of what's being seen. And the specificity here on the right also sits sort of somewhere in the middle compared to those without HIV. But overall, there's a huge amount of heterogeneity here, and that's possibly coming more from the site being tested or the PCR method being used rather than from whether patients have HIV or not. What's likely is that this tool is going to be most useful in those with pulmonary TB compared to extrapulmonary TB, which we know, of course, is more common in those with HIV. There was also a meta-analysis that looked at respiratory swabs overall, so nasopharyngeal swabs being added to the list, but they didn't have any additional cohorts besides for these two that I've presented here with regards to those living with HIV. So essentially watch this space. It's potentially going to completely change how our approach, but we'll have to wait and see. So to summarize, at clinic level, we know that at clinics, there's still a persistent high mortality risk in these patients, and that we're aiming to make these diagnoses at scale. The other potential disconnect that I was sort of briefly alluding to, but not in too much detail, is that there's a drop-off between the point of actually making the diagnosis and when patients actually get initiated on treatment. So you can imagine that at a clinic, if you are performing a test that needs to be sent off somewhere, that patient has to still come back to get the diagnosis and be initiated on treatment. So there's all sorts of other dynamics to consider with regards to wanting a rapid test that can be performed at the point of care. A reminder of the sort of current guidelines, as I'd referred to earlier. And then just to highlight in one quick sentence that there's a push towards parallel testing for patients, particularly in HIV-TB. And so what this means is that we're not going to aim to sort of do a LAM and then think about whether to still do a sputum. The WHO wants us to be doing both at the same time. So concurrent parallel testing of both LAM and sputum, and that's applicable to both inpatients and outpatients. So thank you to everyone for listening and to all the people pictured and mentioned on the slide, and for Prof. Meintjes reviewing the slides. There's obviously a lot to go into in these topics and particular tools, which isn't possible in just sort of a 40-minute talk, but happy to take questions. Yeah. Cool.
Thanks very much, Bianca. That was an excellent talk. I think we all learned quite a lot about TB diagnostics and HIV-TB. So thank you very much. We do have a couple of minutes for some questions. So if anyone wants to unmute themselves, they're more than welcome to, or they can put a message in the chat and we'll read that out for Bianca.
I can't actually see the chat.
I can also read them out for you if there's any.
Okay, cool.
We'll give it a few minutes.
Oh, there.
All right, Graham has his hand up.
Yeah, thanks, Bianca. Excellent overview. I know your focus was on the microbiological tests, but I wonder if you can say something about abdominal ultrasound, which is sometimes used in patients admitted to hospital.
Cool, yeah. So thanks. I'm glad we had kind of prepared this in case there was time to talk about it. So hopefully you can still see my slide. So what's been developed is a protocol you may be familiar with already called the FASH or FASH ultrasound, ultimately standing for Focus Assessment with Sonography for HIV-TB. And this was replicated quite closely, but sort of added to in relation to the FAST ultrasound that we may do in trauma settings. It's ultimately, as you can kind of see, various points of the abdomen looking specifically initially just for fluids, so pericardial effusions, pleural effusions, or ascites at different points, and then some additive checks, if you're able to do so, ultimately splenic or liver lesions and abdominal nodes. With regards to this actually being conducted, it's designed to sort of be conducted at the point of care by sort of front room doctors that are seeing these patients as they come in. You may not have a radiographer who's able to perform this for you. So the idea is if you have access to an ultrasound machine to be able to actually do this test as the clinician seeing the patient. With regards to its actual accuracy, the sensitivity of all those various checks that I've just mentioned sits at around 63% for bacteriologically confirmed TB. And then the specificity sits at around 68%. And of course, we know that we are likely to have specificity issues in these cases, because if you think about all those various fluids or intra-abdominal nodes, there's many potential causes in this patient group. And so all of this testing kind of needs to be followed up with microbiological confirmation. There's amazing resources that have been put online, and there's a Dr. Tom Heller, who's based in Malawi, has produced kind of amazing courses and documents that can be used to go and train yourself or be trained in this potential tool. So if you do have ultrasound available to you, I've linked it here, or hopefully this QR code works to take you directly specifically to those training resources, which will hopefully be helpful. Yeah.
Thanks, Bianca.
Cool.
Any other questions that we have?
Bianca, I wonder if you could say something about how long the tests stay positive for despite TB treatment, and that applies both to what's known of the sputum NAT tests and what's known with respect to the urine lamb.
So on the topic of urine lamb, that's a very common question that we get asked. It hasn't been studied as a treatment monitoring tool, but it is often a concern that potentially a patient is sort of remaining positive after treatment, and how can we still trust these tests? There's been one study that studied this in outpatients with HIV. I don't have the specific numbers on the top of my head, but something along the lines of 5 to 10% of patients should be expected to be positive by the end of the 6 months of treatment. With regards to sputum, we know that, of course, with the ultra tool, we had the added benefit of an additional probe, which gives us those trace results. And we know that those are specifically at risk of being false positives in patients who have been recently treated for TB. The cutoff, there's studies that have kind of studied varying lengths of time, but the cutoff generally deemed as a potential for false positives is patients who've been treated within the last 2 years for TB. So in those cases, you generally want to either repeat the sample or kind of consider the general clinical condition of the patient, potentially send off cultures.
Thanks.
Thanks, Bianca. I see some questions are starting to come through in the chat. So I'm not sure who this is from. It's just a number, but they did ask, can you please tell us about the expert MDR test?
Sure. So there's potentially an expert XDR test that also assesses for resistant to INH, fluoroquinolones, ethionamide, and second-line injectables. I didn't have time to go into all the sort of drug resistance tests as part of this, but essentially that test can be run on the same sort of platform that can run the Expert Ultra. Either what has been studied is in a separate sputum sample or in the pellet of the same sputum samples also being studied. What we know is that it definitely decreases the time to the diagnosis of all of those various drug resistance patterns. And of course, that would be in comparison to how quickly you can make these diagnoses in culture. And it generally is very accurate for those particular tools.
Great, thanks. Yes, they said they meant the expert XDR.
Oh, perfect.
And then I see Jack van Nuftrik posted a question. I'll read it out directly. He has said, have I missed something? What about gene expert and diagnosed HIV? I'm not sure, Jack, if you want to unmute yourself and ask your question or elaborate on your question.
Thank you. I'm not an expert in this field of diagnostics, but I do manage a lot of HIV cases. And isn't it, or what has happened about gene expert in patients that you know have HIV and you want to determine whether or not they have TB as well?
Yeah, so the expert is the kind of molecular test that we are performing on these various samples. So I went into a bit about using it on sputum and using it, for example, on urine. And that is primarily kind of the whole, all of the data that I was sharing is with regards to that. Do you mean with regards in comparison to those without HIV? Is that what you kind of...
No, I was meaning more that you have a patient who's HIV positive, and you know that, you've been treating them, and their condition has deteriorated, and you want to rule out concomitant TB.
Yes, so if you, so definitely the kind of data that I was presenting was in relation to that specifically. So if you have a patient like that and they can produce sputum, that's definitely a test we would want you to do. And in addition, depending on where you're working, you may do a urine lam, but we're hoping that we can expand beyond that, because even in some patients with those tests done, there's still diagnoses that are missed.
Thank you very much.
Perfect.
Hi, Graham, you have your hand raised.
Yeah, maybe just to respond, to Jack's question. I mean, previously we would have used the sputum smear microscopy as the first line test for diagnosing TB in people with HIV, and generally, but the WHO now recommends the sputum expert testing, or one of the other NAT tests that Bianca elaborated on as the first line test for diagnosing TB in people with HIV. But Bianca, perhaps just to expand the answer to that question, if you just I know you weren't speaking about screening, but just maybe refer to the broader use of expert and other NATs where when one might screen people who are asymptomatic in a clinic because of the high prevalence of asymptomatic TB. And that's one approach that has been introduced in South Africa.
So that approach, yes, comes from, I don't know if I'm still sharing my screen.
Yeah, you are.
That particular approach comes from what we refer to as the TUT trial. And this essentially enrolled in a cluster randomized trial, basically control clinics where screening happened based on sort of whatever the standard TB testing guidelines, as we've just kind of gone through, were, and based on the clinicians deciding who needs that. And then at the intervention clinics, this was irrespective of symptoms or CD4 count. Their primary analysis was trying to look at how many sort of TB patients were diagnosed per month between these two arms. And then there was a secondary analysis that compared each clinic with its own prior year. So how many diagnoses were made when sort of standard screening and testing algorithms were done compared to when you performed sputum in all, sputum expert in all, irrespective of the symptoms or CD4 count. And this is what's kind of being demonstrated in this figure, in that there was a significantly more diagnoses being made year on year. And so that's informed a new approach that's going to be rolled out in South Africa, from my understanding, that patients, irrespective of their symptoms, will be tested with expert. And of note in this trial, 71% of them were living with HIV. So depending on the setting, this is, of course, depends whether this makes sense to implement or not. We are in South Africa a very high burden TB disease setting, and so we definitely surpass the prevalence of 10%. But in some other settings, there's a huge amount of literature with regards to screening at a sort of clinic and hospital level, and the decisions being made, or how to inform your decisions with regards to whether you apply a screening method that uses symptoms or something else like a CRP, or whether you kind of decide to rather go with the prevalence approach and just test all patients. That's, of course, not encroaching on the area of sort of active case finding and going out into the community to find patients, but with regards to screening in the clinics or in the hospitals. But yeah, this is a huge amount of information to also talk through. I don't know if that answers your question, Graham.
It does mine. Thank you.
Thanks for the question, Jack. Yeah, cool. I mean, it's clearly the priority, as you say, Bianca, is to use this test to diagnose TB in people who are presenting with symptoms. But if resources allow and the program has the capacity, then extending it to all people presenting for the first time with HIV, or doing annual testing to diagnose TB, it has been shown to have some benefit, but it's really a resource issue then as to whether you can extend it. I mean, it does mean in South Africa millions of extra expert tests a year, and we doubt that the lab will actually be able to cope with that, even if the finances are available. Thanks.
Thank you.
Thank you. And then we have another one one more question. I think we'll take Sunay. So she asked, could you list in summary which tests, both bacteriological and non-bacteriological diagnostics, would you consider for testing TB in HIV patients? So I think a summary.
Sure. So essentially the summary point being, if you can get a sputum, no matter the setting, you want to get that sputum and send it for a molecular test. In the subgroups that I've mentioned, which essentially applies to all hospitalized patients, you want to also perform an allele lam. And then in the sicker patients who are outpatients, we want to perform a allele lam, but it's kind of a slightly smaller subgroup of sicker but still sicker patients. And those two are our frontline tests. They should be performed at the same time together, not sort of thinking about them sequentially. And particularly if you're performing a LAM and it's negative, you don't want to not perform the sputum. If the LAM is positive, you still want to perform the sputum. So those two tests are currently the kind of mainstay of our diagnostics in HIV-TB, but we're hoping that things will expand broader than that so that we can stop missing so many patients.
Great, thanks, Bianca. I think we have answered all the questions that are in the chat, and we have reached the end of our seminar. So thank you very much, Bianca, for joining us today and for giving an excellent talk. Thoroughly enjoyed it, and I think there were some great questions there as well. Yes, and so just thank you to everyone for joining today. Please have a look out in the new year for our new list of seminars that we'll publish, and then we look forward to seeing you all then in the new year.
Thanks, everyone.
Thanks.
Thank you.
Thank you.
Thank you. Bye-bye.
Okay, thank you. Bye-bye.